Hello, and thank you for joining us for today's webinar, eCQMs, Capture Data Once, Submit for Multiple Regulatory Programs. My name is Jennifer Wynn, and I am part of the Spectrumetics team. At the end of today's webinar, there will be a brief question and answer session. Please feel free to enter your questions into the webinar control panel at any time during the presentation, and we will address the answers at that time. Additionally, there will be a break between speakers for a brief poll question. If the question pertains to you, please do take a moment to respond. These questions help us to provide you with relevant information for our future presentations. If you would like materials after this webinar, we will be providing you with instructions via our follow-up email. Our topics for today are going to be what has changed for 2016, aligning measure across regulatory programs for 2016 reporting, electronic data capture processes and workflow adjustments for eCQMs, interface methods for eCQM data integration, the Spectrumetics eMeasures 360 capabilities overview, and the Spectrumetics client engagement process. Today's panelists will be Dr. Raj Lakhanpal. Dr. Lakhanpal is CEO for Spectrumetics, as well as being a member of the HIMSS Clinical and Business Intelligence Committee and a member of the Board of Trustees for the University of Sciences in Philadelphia. Our second speaker will be Mr. Mark Bryant. Mark is Director of Sales for Spectrumetics and is responsible for all new business development and client relations. He was formerly a Senior Account Executive for both Sun Microsystems and Iron Mountain. So without further ado, I will turn over the slideshow to Dr. Lakhanpal.
Thanks, Jen. Good afternoon, everyone. It's my pleasure to present to you. So as I start, why eCQMs? What has changed in the past year or two that eCQMs have become important? The adoption of electronic health records has made eCQMs, the ability to calculate eCQMs easier. And the data is captured electronically at the point of care. So it's not captured retrospectively after the patient leaves the hospital. So that's number one. Number two is it allows us to reduce the chart abstraction costs. So since the data is captured electronically and they can be submitted electronically, chart abstraction costs and the complexities of chart abstraction, where a lot of mistakes may be made, are minimized. With collection of data, you can submit to multiple programs at the same time. And since you're capturing data at the point of care, that can also be used for performance improvement on a continuous basis. eCQMs, as you would have guessed by now, stands for Electronic Clinical Quality Measures. And something I want to emphasize is that all hospitals and ambulatory providers must use for the ONC 2015 guidelines for their eCQM modules for reporting in 2017. Next slide, please. So what has changed for 2016? Why is it important? I think the biggest driver has been that IQR, Hospital Inpatient Quality Reporting, has become mandatory for 2016 reporting. And all the programs have been aligned, and those would be IQR. Can you point to that area, please? IQR, Meaningful Use, the Joint Commission, and PQRS. The reporting deadline is 2/28/2017. That's about 11 months away. And you need to report for either Q3 or Q4 data for IQR, Meaningful Use, and Joint Commission as well. For PQRS, you'll need to report for the whole year. And for the failure to report for hospital inpatient quality reporting will entail a penalty. It's a complicated formula, but it adds up to be between 1.25% to 1.4% of your Medicare inpatient revenues. The electronic submission of eCQMs has to be in a QRDA1 format, and we'll talk more about that as we go along. Now, 2/28/2017 seems to be far away, but as Mark will show to you, you need to start planning for it right away. Next slide, please. So before we talk of eCQMs, before we focus on eCQMs, I want to take a minute to talk about all the programs across the continuum of care, all the clinical quality measures across the continuum of care, both on the hospital side and the inpatient and the ambulatory care side. On the hospital side, the greens, the ones that are shaded in green, are eCQMs. And so obviously on the hospital side, I mentioned HIQR, Meaningful Use, and the Joint Commission. And then you have other programs that are not eCQMs, but are important: hospital-acquired conditions, infections, some value-based purchasing programs, and other inpatient custom measures. Hospitals may be tracking a number of things that they feel are important, and those could be custom measures. Also, similarly, as we transition to value-based care, as we transition to at-risk models, multiple quality measures on the ambulatory care side too. And obviously the eCQMs would be meaningful use. PQRS can also be reported through eCQMs or through a registry. HEDIS measures traditionally have been claims-based measures. HEDIS measures can be reported as eCQMs as well. And then you have a whole set of measures that for value-based care, as well as for pay-for-performance programs or at-risk programs like DSRIP, which is a Medicaid program, ACO measures, patient-centered medical home measures, and a whole number of outpatient custom measures that are again used in pay-for-performance or value-based care. Next slide, please. This is a good slide, and it talks about how data needs to get captured. And we get asked a lot of questions about how do I provide you data. To calculate eCQMs, we need data in a QRDA1 format. We mean spectrometrics, or people like us need data in a QRDA1 format, and I'll talk more about that in a minute. And we found that not many hospitals or not many EMR vendors are able to provide that data easily. There is a fair bit of effort involved in getting data as a QRDA1. So other ways to get data is eCQM data specification file format, where we've identified all the data elements needed to calculate eCQMs, and we provide that to our clients as a data dictionary or in a format, and they can then, if they have the resources, technical resources, they can identify where those data elements are and provide that to us. Or if they say, look, we are not able to do that, we can build a custom agent that essentially pulls that data out of their EMR. And then we calculate the measures, that's the one in the middle, and then we report for meaningful use, HIQR, TJC, and also on ambulatory care side for PQRS, and if you're doing NCQA reporting like HEDIS measures as well. Next slide, please. So I have a few slides just to talk about eCQMs. What is eCQM? We've broken it up into 4 sections. Understanding eCQM data requirements, capturing data and remediating gaps, eCQM calculation and improvement, and electronically reporting eCQMs. What I'm going to do is I'm going to use the stroke 2 measure to illustrate, to give you an example of how this is done. And the stroke 2 measure is ischemic stroke patients prescribed antithrombotic therapy at hospital discharge. So if you look at that measure, the denominator is all patients who were discharged with a principal diagnosis of ischemic stroke. And the numerator in this case will be patients that were prescribed antithrombotic therapy at hospital discharge. So taking that example, let me go through these 4 sections. Next slide, please. Yeah. So the first concept is that eCQMs follow a quality data model. So so it's called a QDM. And the difference between the QDM and and what was being done prior to that through manual abstraction was that QDM follows a certain standards and value sets to capture a specific clinical event. And in this case, administering antithrombotic medicines prior to discharge. So they will follow a standard. For example, the code sets will be standard as RX norm code sets. And within that, and the value sets will be, or quality data types within that would be the dose, the frequency, the refills, the route of administration. So everything is much more standardized than it was before, so that you have to capture data in that specific format for it to be available for eCQM calculation. And new to eCQMs is that denominator exceptions are, for example, patient refused medicines or patient was allergic to medicine are applied. But keep in mind there is no measure category assignment for missing data elements. So you cannot say data missing as you report these out. So since you are collecting data in a very structured format, you will probably need to make changes to your clinical workflow, and so that you can remediate any data collection gaps. And keep in mind that eCQM specifications change every year. So new data elements may be added, some data elements may be removed. So your workflow modification to a moderate extent may have to happen every year. And using the wrong data collection or using the wrong data specs will lead to incorrect results. So right now, as I mentioned earlier, you need to be, for 2017 submission, you need to make sure that your EMR vendors are using 2015 guidelines. Next slide, please. And so this talks about eCQM measure components. As I mentioned earlier, there's a denominator in our example, all patients discharged with a diagnosis of ischemic stroke, principal diagnosis of ischemic stroke. There's a numerator, patients that received antithrombotic therapy upon discharge. And then you have exclusions. And the exclusions in our case were, examples of exclusions were patient refused meds or patient was allergic to meds. So, so that's how the eCQM, you got to collect data in a quality data model format, and then you have the numerator, denominator, and the exceptions. And since you are capturing data at the point of care, tracking this on a weekly basis, tracking this on a daily basis can lead to much stronger quality performance improvement than that was possible in the past. Now, the final section is, how do you report them? How do you report eCQM? So they're reported, it's a standard HL7 format. It's called, as I mentioned earlier, it's called QRDA1 format. And it says QRDA1 Category 1 CDA format. CDA stands for Clinical Data Architecture format. And that contains the patient's, all of the patient's quality data, and also the demographic information. And that needs to be reported to CMS for that particular reporting period. So in our example, for HIQR, MU, or TJC, it's Q3 or Q4 of this year. And the QRDA1 will be submitted for each patient that meets the initial patient population for one or more of the eCQMs. Next slide, please.
Great. Thank you, Dr. Lakhanpal. Okay, it is time for our survey question. And for today it is, what do you see as your biggest challenge with eCQM reporting? So we'll give you a few moments to answer that question, and then we'll be back with the results. Okay. And Nathan, can you launch this? There you go. All right, so here are our poll results. Okay, it looks like extracting the data, predictably, is one of the biggest problems that we're seeing here, followed quickly by generating the QRDA1 file format. So thank you very much for your responses. And moving on to Mark Bryant.
Yeah, thank you, Jennifer. Good morning, good afternoon, everybody. We greatly appreciate your time and interest today. So for my portion of the webinar, I'm going to give you a brief background on who we are, what we offer, then launch into what our eMeasures 360 platform capabilities are for eCQM reporting, and then the last portion talking about our engagement process. So first, Spectrumetics helps health systems facilitate the transition to value-based care and alternative payment models. And we do that in 3 ways. The first is the ability to consolidate data across disparate systems. And that's going to be important, as you saw with the poll question, giving you the ability to wrap your arms around the data so that you can report on the eCQMs. The second piece is, and the backbone of our company, is our measure framework. And so we're able to calculate and report on measures for both hospital and ambulatory programs. So for your eCQM on your hospital side, and as you transition into other programs, PQRS on the ambulatory, as that moves into MIPS, and if you're part of any ACO or district Medicaid reform programs, we can assist there. And the third piece is predictive modeling. We're not going to focus on that today, but we can offer on predictive modeling for inpatient, for readmissions, hospital-acquired conditions, value-based purchasing. We can provide you analytics. So again, you can track your performance, be able to maximize incentives, and avoid any penalties. And we also offer population health analytics for geomapping, risk stratification, and dynamic disease registries. At the bottom of this slide, you'll see a small list of our clients and relationships. Happy to provide you a full list if you wish. But just to take a moment on these, first and foremost, Haney Solution, which is a division of the Hospital Association in New York. We're very proud of our relationship with them. They've endorsed us for our PQRS solution. Quantros. Quantros is distributing our eMeasures platform to their clients. So if you're a Quantros hospital on this call, what you see today is what you'll be offered through our joint relationship. If you have any questions, you can certainly engage with the Quantros sales team or directly with us as well. Greater Hudson Valley Health System and Auburn Community Hospital have engaged with us for PQRS 2015 reporting. Richmond University Medical Center is using our analytic platform for data consolidation from their multiple EMRs, analytics for readmissions, hospital-acquired conditions, and value-based purchasing. And on the bottom right, the Staten Island Performing Provider System. This is an entity underneath New York State Disrupt. And for them, we are consolidating data of their Medicaid lives that are attributed to their region. We're providing them a measure framework so that they can calculate the measures that are attached to their programs, their projects, so they can maximize their incentives, and population health analytics so they can understand their community and provide outreach based on risk stratification and geomapping. So our eMeasures 360 platform, first and foremost, we're certified for all 29 hospital eCQMs. So we can help you report on the 4 mandatory HIQR eCQMs this year, along with meaningful use and the Joint Commission. We can also build measures for HAC-HAI, value-based purchasing, and any other custom initiatives your hospital, your health system might have. On the ambulatory side, we're certified for all 64 eCQMs to report for PQRS and meaningful use. We're also a qualified registry with 170 measures built to report for PQRS measures. As Raj had mentioned, as HEDIS transitions to electronic, we can support STAR ratings and paper performance programs, Disrupt programs, ACO measures. When patients at a medical home, when NCQA develops measures, I believe next year for those, we will be able to support that, and any other outpatient custom measures as well. This next slide just summarizes what I stated, but I just want to point out two key areas. First is NCQA had approached us last year to be part of their pilot program to develop those eHEDIS measures, so we successfully helped them develop 4 eHEDIS measures as they make the transition. And then our measure platform is consistently updated as new measures are published or changed, and I'm going to walk you through now what the platform looks like for being able to create measures and how do we capture the data, and then show you a couple of slides on what our portal looks like. So first is underneath our measure framework, we have what we call our measure authoring tool, and we believe this is a differentiator that can really be of value to you, not only for eCQMs, but as you transition to other programs. So we can rapidly define measures, variables, and calculations. So as things are changed, as new measures are published, as CMS changes requirements for the eCQMs year over year, we handle all of that through our tool. We can then create custom programs, whether it's for commercial payer, if you're involved in Medicaid reform, if you're a clinically integrated network, which then allows you to have those measures to be able to pull the right data, to calculate them, and then to be able to track them through our portal for performance improvement and to maximize your incentives. So the first step for the eCQM process is understanding where the data is and what the data elements that we need to capture. So we'll work with you and your EHR system to be able to make sure we can pull in the right data, and that data could exist within the EHR in pharmacy data, laboratory, ED. We can marry that with any billing claims data as well. We consolidate the data, and then we map it to the specific data elements for the measures you're looking to track for 2016, and then we standardize it. An example of standardizing it would be to deduplicate any patient information. That's then populated into our enterprise data warehouse, where we'll then calculate measures. And this is an ongoing process. So as we give you a performance improvement tool and you update a measure, you update a patient's information, and then we pull that information in on a batch process, whether that's weekly, biweekly, monthly, quarterly, however we set it up with you. It'll go through the same process of consolidating that data, mapping it, standardizing it, and populating the enterprise data warehouse. So Dr. Lockenpaul had showed you this slide earlier, so I'm not going to spend a great deal of time on it, but just want to emphasize again that we can give you options in order to get the right data, in order to calculate your measures and satisfy the requirements, specifically HIQR for this year. So if you can produce a QRDA, we can ingest that file. If you cannot, we can provide back that data dictionary that Dr. Lockenpaul had mentioned, where we provide you within a format the data categories and the data elements that are needed. We then work with your team to make sure that that's populated. We get that back from your team, from your quality and your technical team, and we can ingest that file format. And we can also build a custom interface as well. If you cannot give us the right format, if you can't get us a QRDA or the data specification file, or if you just want to capture additional information that's besides what's needed for the eCQMs, we can map in, pull that data on an ongoing basis, layer our framework around it, and then provide you back the reporting tools that you need, both through our portal for performance improvement, and then we would handle the submission to the various regulatory bodies for HIQR, meaningful use, Joint Commission, and so on. So our portal is completely customizable, and we'd customize it prior to implementation with you. But we offer 4 key roles with portal. The first is an executive role. The executive could be your chief medical officer, could be chief quality officer, director of quality and improvement. Who's ever in your health system is in charge of your HIQR, meaningful use, Joint Commission, any of your ambulatory programs. They would log in and from an enterprise level be able to see how you're performing against each of those programs, and then be able to drill down into the specific programs to see performance by your hospitals, by your provider, so you can have it. They can have an ongoing method to see where you stand and how to improve going forward. The second role that we offer is a provider role. This is very key when you're looking at an ambulatory program such as PQRS, that the provider can log in, see their patients as an aggregate, and then be able to drill down into that information to see gaps in care and utilization. We also provide disease registries as well. Then we offer an analyst or an informaticist role. And this person, he or she, would log in if they're in charge of HIQR. They'd be able to see the measures that you're tracking, so you can track just the 4 that are mandatory, or you can select, you can go up to 28 eCQMs available to be able to look at those on an ongoing basis, to be able to then drill down into the measures themselves to see patient-level details and to address any gaps, and I'll show you what that looks like. And then the fourth role is a submitter role. And the submitter would log in prior to the deadline in February of 2017 and be able to select the measures. So if you're tracking more than the 4 mandatory for HIQR, you'd be able to select the measures that are performing the best, the 4 performing the best, click a report function, which will then generate a report to us that we format and send it off to CMS. If you're also looking at the Joint Commission measures, we'd be able to format that and send that off separately to the Joint Commission, as even though they both accept QRDA1s, they're formatted differently for that. So the next 2 slides are a snapshot of our portal. We'd love to go into greater depth as a demonstration on it, but for sake of time on a webinar, we just wanted to offer you 2 quick snapshots, but happy to show it to you at any point. So the first is the executive role. So again, the executives, the first screen that they see is a summary of the programs they're looking to track. They can then drill down into the program. So in this case, they're drilling down into HIQR. They're looking at it down to a hospital level. What are the measures that the hospital is looking to track for the year? And then how are they performing? And what you'll see here is benchmarking. So prior to implementation, we offer 2 benchmarks per measure. These are customizable for you. They could be a national, a state benchmark, and also an internal target. So you could see how you're performing. Green you're outperforming both. Orange, you're underperforming one of the benchmarks. Red, you're underperforming both benchmarks. And then you're able to drill down further into the measure to see provider comparisons and have that opportunity to improve. On the flip side, we also offer an analyst role. And so the analyst is going to log in this case, into HIQR, see the measures that he or she is tracking for the year, be able to drill down into the measure to see patient-level details. And this is important because then they can see who's qualified for the numerator and if there's any exclusions or exceptions and why. So if there's an exclusion, for instance, for F. Brown, patient F. Brown, because there's data missing, there's the opportunity to go back to the EHR, correct the data if possible. There could also be workflow issues as well that can be addressed. Through this role, there's also the submitter role, where they would then be able to go in and select the measures. Again, generates a report to us that we would then submit off to CMS and to the Joint Commission. So that's the eMeasures 360 platform, and a quick look at the portal, the tool, performance improvement tool itself. The last couple of slides are around our engagement process. There's four engagement steps. First step is an assessment, which I'll go into greater depth in a second. Then there's a remediation period where you can work on the measures to fix them, to select the right ones you want to report on prior to implementation. During implementation, we'll build out the website to your specifications, and we'll also train your team on it. We then go live and provide ongoing support from there. So the assessment process, the first step is we have a short little survey just to understand what programs you're looking to track, which measures, and which EHR or EHRs you're utilizing. Once we understand that, we go into a formal assessment process. During this, we'll ask for a month or a quarter's worth of data to run that against the electronic clinical quality measures, all 29 of them, and show you first and foremost, can you report on the 4 mandatory HIQR measures for this year? Can you report for Joint Commission for meaningful use? Do you have the right data, or will that file fail upon submission to CMS or the Joint Commission? We also show you the performance currently against each of the measures. So just like in the portal for the analyst role, we're going to give you a report back during the assessment period that shows you how you're currently performing against each of the measures, so you can start to do remediation then prior to implementation, which will then lead into implementation. We'll work with you to select the measures and then go live. So once you go live and throughout this process, we're here as your partner. We offer a SaaS cloud-based model. We offer continuous educational points, so we do webinars for our clients throughout the engagement. And we also offer full support. So we update the portal. We'll work with you on the ongoing data collection. We'll give you the portal for that quality of, improvement and data governance. We handle all the submission. We take that burden off. And then as specs change, we handle the specification changes, and if that changes anywhere, if that causes any changes into what data we need, we'll work with you to make sure we're capturing the right data on an ongoing basis. So finally, to summarize, whether you've begun the transition or you're just getting ready to start, we believe we can offer a lot of value to your organization. We'd love the chance to prove that. We think the assessment process up front will be a great tool for you to see where you currently stand and be able to position you in the right place to be successful this year for reporting. We can capture all the data from different sources and mitigate any data gaps. We can identify the right measures for you to report on for this year and then build a strategy for expanding that in the future, which will help you to move away from the manual chart abstraction. We give you the portal to track your programs on an ongoing basis, and we'll generate all the QRD files needed to successfully accomplish submission this year and avoid any penalties. We greatly thank you for your time. We hope you give us the opportunity to prove that we can be the right eCQM and quality improvement partner for you. We're going to have a short question and answer session. Joining us for this is our product manager for our eMeasures 360, Kumar Kwandasamy. My contact information is below, so please reach out. We'd love to speak with you. And with that said, I'm going to turn it back over to Jen for the Q&A.
Great. Thank you very much, Mark. All right. I'm actually going to just address something that just came in, only because it's relevant to what we have on the screen here. So if you need to reach out to us for any reason, you can call our offices at 609-336-7733. If you'd like to speak to Mark directly, his extension is on the screen for you there. It's at 313. But any of us would be happy to help you out. And you can also email us at our email addresses, which are all our first name dot last name at spectrumetics.com. So thank you for that question. So first question up here, let me just get back to my beginning here. All right, what are the critical access requirements? Kumar?
Yeah, hi. So critical access hospitals are also required to report eCQMs, especially for the hospital IQR program. The requirements are the same as the acute care hospitals. They have to report 4 eCQMs electronically. For the Joint Commission, on the other hand, it's optional. eCQM reporting is optional. And then if they decide, or if they select to report eCQMs, they have to report 4 eCQM measure sets to satisfy Joint Commission reporting.
Okay, the next question, I think this is also for you, Kumar. When will the portal be available to submit a test file?
We are ready to take in sample files or test files. What we do is, as part of our implementation is, we take in sample files and we conduct a readiness assessment. Mark talked about the different steps in the readiness assessment. So, please reach out to us, and we can work with you to set up a secured file transfer portal to receive those sample files or test files.
Thank you. All right. And could you clarify the difference between exclusions and exceptions?
Good question. So exclusions and exceptions. So exclusions are applied after qualifying patients for the denominator. Patients could be excluded for various reasons. Some of the common ones are, transfer to another hospital, transfer to a SNF. In those cases, patients are excluded from the denominator. Exceptions, on the other hand, happens after applying the exclusion criteria. And some of the common exceptions are patient refused medications, or patient is allergic to certain medications. So those patients are, even though they are not excluded, they qualify in the denominator, but exceptions are applied so that they don't impact your performance scores when you report the data to CMS.
Thank you. Okay. Do you work with Meditech?
Yeah,
you want to answer this question?
Yeah, yes, we do. We do have engagements both on the eCQM side and also on our analytics side with Meditech hospitals. And to answer across the EHRs, we have experience with multiple EHRs, including Epic and Cerner and others as well.
Okay.
Oh, I've got more down here. Hang on. Bear with me. Sorry. Got a lot of questions. I didn't see them. Okay. Let me see here. Okay. Can this reach out into the ambulatory environment for physician PQRS outpatient measures?
So for PQRS, yes, you can report eCQMs to satisfy PQRS, and that will also satisfy meaningful use component of EP reporting. For PQRS, you have to report 9 eCQMs across 3 domains, and that's for the entire year. It has to be in either QRDA1 or a 3 file format, and we are certified for all 64 EP eCQMs, and we are happy to talk to you in detail on what file formats we can take in to satisfy PQRS.
Can you elaborate on our process other than eCQMs?
Yes, we also are a certified PQRS qualified registry. We have close to 170 PQRS measures. Also, we support individual reporting, measure group reporting, and the group reporting. If you're not ready for eCQMs for PQRS this year, we can also help you with reporting eCQMs using your administrative data and clinical data using our registry option, and also help you with transition to MIPS, which is starting next year.
We have another interfacing question. Do you have any experience interfacing with Cerner Sorian?
Yes, we have experience interfacing with Cerner Sorian, especially on the hospital side to calculate eCQMs.
Can any and all of the calculated data be made available back to us for incorporation in internal reports and dashboards, summarized at the physician level at least?
Yes. So after calculating any measure, we can give you the data back in 2 formats. One, the calculated results, and the second format will be the individual patient level data. And yes, you can use the data for internal analytics. Also, a portal has an option to export data out right from the portal. That's another way to get the data out of our system.
Next question is, do the 4 CQM third and fourth quarter option apply to acute and EP attestation or just acute?
It is just for the acute care and the critical access hospitals on the hospital IQR reporting. EPs have to report the entire year for meaningful use and PQRs.
Okay. If we want to submit eCQM for both meaningful use and IQR programs, will we need a full year of data?
For meaningful use, if you are in the first year of reporting, you only have to report for a quarter. But if you are in the subsequent years of meaningful use, yes, you have to report the entire year. For meaningful use and IQR combined, if you're planning to report once, it has to be in a QRDA1 file. The other option is you can report 4 eCQMs for hospital IQR electronically and do the manual attestation for meaningful use 16 measures.
Will the system alert us if any required data element is missing, i.e. not entered electronically by the provider?
Yes, the system gives you 2 areas to capture or alert you about data issues. One, on a high level, when we process your data, we capture very high-level information, patient demographic information, and that triggers an alert. And the second set of alerts are eCQM specific. Based on the measures you select, we configure the alerts to identify patients who do not meet certain criteria based on the eCQM specs.
Okay. All right. I think that's actually all of our questions for right now. Great. As I mentioned earlier, we will be following up with you via email to provide you information on how you can have a recording of this webinar. If you would like an actual demonstration of what we do, though, we would be thrilled to hear from you. You can email any of us, or you can call the number that's on the screen. Thank you very much for joining us for today's webinar, and we hope that it has been helpful for you. Have a great afternoon.